Diagnosing IPF can be difficult because it requires specific diagnostic testing, such as lung imaging using a high-resolution CT scan. The median time for first symptom to diagnose is between 1 and 2 years. As difficulty breathing, dyspnea on exertion, chest discomfort, and many of the other symptoms experienced by patient mimic the respiratory and cardiovascular disease such as COPD, asthma, and congestive heart failure. This misdiagnosis occur in around half of the patients. A chest x-ray would be one of the most diagnostic procedures that would be performed as part of the comprehensive assessment. A chest x-ray may not show the specific disease tissue, but can be used to rule out other diagnoses. It is noted in most research articles is the presence of honeycombing in the lung tissue as a part of the disease process. Included on this slide is the picture of a CT scan. You are looking at the cross-section image that is produced by high-resolution CT scan that demonstrate honeycombing in some of the left lower lung. In the echocardiogram is another diagnostic test that an advanced nurse practitioner would order for diagnosis and management of the patient. The test uses ultrasound to visualize and assess the function of the significance due to IV contrast for the CT scan. In acute phase, such as the acute respiratory distress, atrial blood gases, ABGs, may be assessed. Another important lab value, as well as D-dimer, related to increased incidences of pulmonary embolism with these patients, and B-natriuretic peptide, BNP, if heart failure is suspected. The next category of diagnostic studies is lung functioning tests and assessments. Respiratory efforts and rate, as well as auscultation of lung sounds, is part of every patient assessment. But pulmonary fibrosis and idiopathic pulmonary fibrosis, over 80% of patients with IPF have a distinctive Vector-like cracking sound that can be detected through a stethoscope. The collective pulmonary function test, PFT, results have proven to be very helpful in making the diagnosis and in monitoring progression of IPF over time. A decrease in FVC of 5% to 10% over 24 weeks is considered to be a significant change and related to a twofold increase in mortality in the next year. An initial assessment of pulmonary function and regular reassessment, possibly as often as every 3 months, is valuable in checking on the patient's status. Exercise stress test or nuclear stress test will show heart and in turn also lung function. Oxygen saturation less than 94% on room air may need supplemental oxygen.